So the last slideshow that we'll go over that's going to be included on exam 1A are your junctional dysrhythmias. There's a few junctional dysrhythmias that you're likely to see, but not very highly likely to see. Now the thing to talk about is what makes it a junctional dysrhythmia. A junctional dysrhythmia means that the origination occurs around the junctional tissue. And that means that's going to mess with the look of your P wave, okay? So I'll talk to you a little bit, and hopefully you can see this. If not, I'll cover it again in class. But if you look at your heart and look at this as your atria, here's your SA node where we really want the impulse to originate. If it does not originate in the SA node for whatever reason, maybe there was an MI that occurred over that particular tissue, maybe there's a congenital anomaly, maybe there's been a trauma, a rib that's ridden and ripped that tissue, whatever it may be, whatever's causing that SA node to then not act as a pacemaker. The beautiful thing about the heart is there are multiple backups, and you have backups to the backups to try to get that heart to beat itself, cause it its own automaticity. The second backup is for the internodal trackways to start being the pacemaker. If the internodal trackways tend to be the pacemaker, then instead of having an upright P wave like you would see if the SA node was the pacemaker, if the internodal trackways are the pacemaker, you'll start to see that P wave dampen a bit, get a little bit smaller and a little bit smaller until eventually the pacemaker starts in this tissue surrounding the AV node, which is right here. This is the AV node. The tissue that surrounds the AV node is called junctional tissue. So when that pacemaker originates anywhere in the junctional tissue, then you're going to see either an absent P wave or an inverted P wave, okay? If the tissue, if it originates from right here, then you're likely to see an inverted P wave, because that occurs right before that signal goes down to the junctional tissue. If it occurs right over the AV node, then that signal is going up and down simultaneously. So the P wave is likely to be absent. You won't see it. It's there, it's just buried in the QRS. Now the very weird thing that can occur, I personally have never seen it, I've never seen it on an EKG, but it does occur, is if this very bottom of the junctional tissue becomes the pacemaker. That's right before it falls, the pacemaker falls into the ventricle. The pacemaker's the ventricle, it's bad, and we'll talk about that later. If that occurs, then what you might see is a QRS with a blip that follows it. You'll see a small thing, and then you'll see the T wave occur, okay? That is the junctional tissue that's at the very bottom acting as the SA or acting as the pacemaker. So if that occurs after the QRS, the weird thing about it is that P wave will be upright, be very small, and then you'll see a distinct T wave. Again, very unusual to ever see that. I doubt if any of you all will see that in your career, even if you go into cardiology. Typically, you're going to either see a P wave that's upright, meaning the SA node is the pacemaker, a P wave that's starting to be dampened or decrease in its size. That means that your pacemaker is moving down the internodal trackways, and then when it gets to the junctional tissue, it's either going to be absent or inverted. Either one, an absent P wave or an inverted P wave means it's a junctional rhythm, okay? So that's what this is. And again, remember, the junctional rhythm is working off the SA node, so instead of 60 to 100 beats per minute, that's normal for the SA node, what's a normal rate for the AV node is 40 to 60 beats per minute, which generally most humans do not do well with. So when the junctional tissue, specifically the AV node, takes over as the pacemaker, it usually has to work much harder and beat much faster than it's used to keep the heart rate to a sustainable level. So the bottom line is, any time that the SA node is not the pacemaker, ultimately that patient needs to get a pacemaker. Even if the heart rate is normal for them, 60 to 100, it means that the junctional tissue is working too hard, and eventually the patient will get a pacemaker. Now, how emergent they get that pacemaker, or how later on in life they get that pacemaker will totally depend on what else is going on, how the patient is handling it, and obviously the ultimate decision from their cardiologist. But a pacemaker is the first thing you need to get in your head when you start to see a junctional rhythm, okay? Not an anomaly, but a junctional rhythm. So the first thing we'll talk about is the anomaly. The anomaly is a premature junctional contraction. The exact same thing as a premature atrial contraction, but in this case, that extra beat is originating from the junctional tissue. So just like the premature atrial contraction, which is originating from the SA node, this is originating from somewhere around the junctional tissue. So again, just like with the premature atrial contraction, this is just an anomaly, a blip on the screen. There's an irritated part. Something is beating when it shouldn't be, but we usually have a very distinct underlying rhythm. In this case, if we start from the left side and you measure between here, you can clearly see this is spaced. You go to this, exactly the same, very regular. You go to here, there's a problem. This beat is early, okay? You go from here to here, it's not the same. But you go here to here, and the space between it is exactly the same as this. When you go to calculate that out, your heart rate is significantly below 60, so this is sinus bradycardia, okay? P wave is upright. It's not peaked. There's one here before the QRS, one here before the QRS, looks the same. But on my premature beat, the early beat, I noticed distinctly that that P wave is inverted. So I know right away that's a premature beat and the P wave is inverted. So those are the two things that have to occur to have a premature junctional contraction. It has to be early, that is definitely early, and the P wave has to either be absent or inverted. In this case, it's inverted. That's a premature junctional contraction. If I wanted to make this a premature atrial contraction, all I would simply do is make that P wave be upright. It would still be early, but the P wave would be upright. In this case, it's inverted, so it's a PJC, not a PAC. All right, my P waves are fine with my underlying rhythm. I go to measure my PR interval with my underlying rhythm, and it's about 4 little boxes. It's fine. My QRS is fine. I do see that I have ST segment depression, about 2 millimeters. So my underlying rhythm is sinus bradycardia with ST segment depression. Okay? But I also have to address this anomaly. So at the 4th complex, I have a PJC. So the correct diagnosis for this EKG arrhythmia or dysrhythmia is sinus bradycardia with depressed or depressed ST segment elevation or ST segment depression and a PJC at the 4th complex. What's my treatment? Drive it off the heart rate. My heart rate here is somewhere in the high 30s, low 40s. Again, you calculated that. So like a sinus bradycardia, you'd have to treat with or without symptoms. Do I treat this PJC? Not by itself, no. Now, if that PJC became more and more prevalent, then obviously I've got an irritated spot somewhere in my junctional tissue that's throwing out this extra signal. So the more irritated that spot gets, then they may go in and try to ablate it, okay? So that's right now the treatment modality for this patient would be driven off the fact that this patient's in sinus bradycardia, okay? So this is just another one here. It's a little more difficult to see, but you can notice that there's upright P waves. This is very regular all the way across, and then that's a very early beat. Doesn't go back to regular, but there it does. It's regular. Another early beat, and I'm assuming it goes back to regular, okay? So when I look at my underlying rhythm, just by looking at it, I would say that's a normal sinus rhythm with ST segment depression here, okay? But I have an early beat at the 5th complex and 9th complex, I believe, if I've counted that correctly. But when you look at those early beats here, you notice the P wave is absent. Same thing with here. There's enough room for that P wave to occur, but it's clearly absent. So this would be normal sinus rhythm with ST segment depression with 2 PJCs. What's my treatment? At this point, probably just oxygen because of the ST segment depression, okay? But obviously, if these PJCs are new, just like anything else that's changed, then maybe someone needs to be notified, most likely the cardiologist. But when we get into the actual rhythms where the SA node, for whatever reason, has quit altogether, being the origination of that impulse, that pacemaker site has now clearly moved into the junctional tissue. Then we get into what's called the junctional rhythms. The thing to remember about the junctional rhythms is it does not matter what the heart rate is. The ultimate treatment is a pacemaker. Now, how fast or how slow that heart rate will be will depend on whether that pacemaker is going to be put emergently in, which means right away, or they can live with that rhythm for a while and eventually they might put a pacemaker in. But a pacemaker is really what we want because we don't want the junctional tissue to be the originator of that impulse. So just keep that in mind, okay? So when we're talking about junctional rhythms, not blips on the screens, not PJCs, these are actual junctional rhythms where the impulse is originating from the junctional tissue. A junctional rhythm, nodal rhythm, or escape rhythm, sometimes it's called a junctional escape rhythm, meaning that the impulse has escaped from the SA node. It's not a very common dysrhythmia, but it does occur. Multiple names. Pick one, call it that, okay? You'll probably hear junctional escape rhythm more so than you'll hear any other combination of names. Usually it's very regular. You can see here it's regular. The rate is typically 40 to 60. To call it a junctional rhythm, you cannot have a rate above 60 because that's the normal for the AV node, is to have a heart rate between 40 and 60. Unfortunately, most patients are going to be symptomatic if the heart rate's between 40 and 60, but that's normal if the AV node is now the pacemaker, so keep that in mind. The P wave, again, it usually occurs before, and it's usually either absent or it's inverted. It can occur after, like I showed you, but that's so rare, you won't see that. The PR interval, if the P wave is inverted, you can measure it. It's usually going to be less than 0.12, I'm sorry. It's usually going to be less than 0.12, okay? If, again, it occurs before the QRS, it's going to be inverted. You can measure that. If it's absent, the P wave's absent, or the P wave occurs after the QRS, which I don't have an EKG slide, so it won't be that way on the test, then just tell me it's immeasurable if the P wave is absent. The QRS, again, the signal's coming from the atria, so it's typically normal. It's usually going to be within the normal limits. So as we look at this, you can see that to see regularity, we only have these, but it's perfectly between the two. So we know the underlying rhythm is regular. We can calculate that. It's going to be the high 20s to low 30s. We don't see a distinguishable P wave here. This is probably the clearest of them. We cannot measure the PR interval. So on a P wave, put absent, PR interval immeasurable. We can measure the QRS. It's about 2 boxes. It does not have ST segment depression or elevation. We do have a T wave, and while it looks large, it's not peaked. It's about 5 millimeters, but it's not peaked, okay? So this is clearly a junctional rhythm or junctional escape rhythm. If you calculate this below 40, you can say junctional bradycardia, but most of your clinicians will just use junctional rhythm, okay, to denote it if it's below 40. It just means that your treatment is going to be much more on the emergent side than not. So when we move into the faster heart rates, it just depends on what the heart rate is. Accelerated junctional simply means a junctional rhythm that the heart rate's between 61 and 100. Same parameters apply. Junctional tachycardia, which we don't see very often, means that the heart rate's between 101 and 180. Here's some examples of junction. These are both accelerated junctional, I believe. But everything else is the same. But even though, because you can clearly see there's no P waves here, right? Even though the heart rate is somewhat sustainable, and most of the time the patient won't be symptomatic because we're producing enough cardiac output via the heart rate, it's still overworking the junctional tissue. So a pacemaker, to get that impulse back up to the top part of the atria, that's going to be the ultimate treatment. It's just that these patients probably won't be treated on an emergent basis because they have a sustainable heart rate, but it may not last very long. So again, typically, if the junctional tissue has taken over as the pacemaker, then a pacemaker is usually going to be the treatment modality. Okay, so initially treat it off your underlying heart rate. So that's the last of the slideshows that are included in exam 1A. Again, we will be going over multiple slides in practice in class. Feel free to watch these videos multiple times to make sure these concepts are solidified.